Well, people can continue joining as we go. I think we should make a start if everyone's all right with that. Yeah, great. Everybody on the panel, fantastic. Good morning, everyone. My name's Kat Tranter. I'm based at Lancaster University, and I'm a member of the research team hosting today's event, the ADR England Community Catalyst Children at Risk of Poor Outcomes project. It's a real pleasure to welcome you here today to today's event. This is the fourth event in a series of seven so far, which we're programming throughout the year. And each of these events is showcasing administrative data research, which connects to a number of priority research areas that, as a project, we have outlined within our project research agenda, which we published earlier in the year. If somebody was able to post from the team a link to our microsite, which hosts our reports, including that research agenda at some point, that would be brilliant for you to go and have a nosy. So this morning's event is seeing us together to consider one of these priority areas, which is arguably one of the most important and complex areas in relation to public policy and practice, that of understanding and evidencing the impact of preventative services and early interventions upon the lives of children and young people. So this event, like all of ours, are bringing together our building together our community really of researchers, practitioners, and policymakers united by shared commitment to use data not just for measurement but for public good. And it's really great to see so many of you registered and here today. So thank you for coming on this windy Monday morning, windy up here in Lancaster anyway. Um, so, it can be argued that this research has never really been more vital. Public services face more pressure to do a lot more with less. So the ability to generate robust evidence-based insights about what works, for who, and in what context is absolutely crucial. So our three fantastic speakers today are going to showcase work which draws upon local and national administrative data sets from across social care, health and education sectors to meaningfully inform our understandings of support for children, young people and families at that preventative stage. So from evaluating interventions to identifying systemic challenges, this research is going to highlight some of the key pathways we can make towards progress. Unfortunately, Sarah is unable to join us today, but we really hope to showcase some of her work at a future event. I'm going to introduce our three speakers, each prior to their presentation. But just before this, could I point out that we're going to be sharing the QR code, our QR code link, which you've just seen, hopefully, on a holding slide. Maybe the holding slide's still up, I'm not quite sure. If you haven't spotted that, we're going to put it up again at the end of the event. That links us to a short event feedback survey, just takes a couple of minutes. We'd be really, really grateful if you could spare that time to complete that. That'd be really, really useful. So we're going to have our presentations in sequence after I've introduced our three speakers, and I encourage you all to ask questions, comment in the Q&A function throughout the presentations. We're then going to explore as many of your questions and your comments as is feasible within a combined Q&A slot, which will follow Eliazar's final presentation. So thanks for being here, and I look forward to a thought-provoking programme, and I'll just introduce our first speaker, which is Professor Katie Harron. Katie holds a position of Professor of Statistics and Health Data Science at the UCL Great Ormond Street Institute for Child Health and is a co-investigator within the Community Catalyst project team. Katie leads the ECHILD, that's the Education and Child Health Insights from Linked Data project, which integrates data from across public services to provide understandings of the factors influencing child health and development across England. Today, Katie's going to be given an overview of research which evaluates an intervention called the Family Nurse Partnership. This is an early intervention aiming to provide support to first-time teenage mothers in England from pregnancy to the point of 2 years old. So Katie's going to talk about how she's used linked administrative data across sectors to evaluate the FNP, and she's going to discuss findings, but also some of the challenges I think faced in evaluating interventions such as this using administrative data. So yeah, I'll give the floor to you, Katie.
Thank you. Can you see my slides? Okay. Yes, good.
Yeah.
All right. Thank you, everyone, and thank you for coming along so early on a Monday morning. So yeah, Kat's told you what I'm going to talk about, so I'll just talk about it. Right. So the Family Nurse Partnership, it's an early home visiting intervention supporting first-time teenage mothers from early pregnancy until the child turns 2. And during this period, mothers can receive up to 64 visits from a trained family nurse. It's one of the only early intensive interventions that's recommended within the Healthy Partnership programme for the under 5s. Most of the evidence for the positive effects of the family nurse partnership came from 3 trials in the United States and were for mothers enrolled in the 1980s and 1990s. And this evidence showed that the family nurse partnership was associated with improved health, child health and development, decreases in child maltreatment, and some improvements in some maternal outcomes. However, when the family nurse partnership was brought over to England, a randomised control trial was set up here called the Building Blocks trial. And this trial found little evidence of effect on primary outcomes of smoking, birth weight, hospital admissions, and repeat pregnancies, early repeat pregnancies, or in the follow-up study on maltreatment outcomes, although there were some benefits observed in child development. There were a number of reasons why these differences might have occurred, and there was a lot of debate over the results of the Building Blocks trial. Firstly, usual care differs quite substantially in the US and England. So teenage mothers in England would receive as standard a lot of higher levels of support, which may mean that incremental benefits of this intensive home visiting service might be harder to detect. And this is backed up by the US trials finding that the greatest benefits were seen in the most deprived mothers. And then the choice of outcomes in the Building Blocks trial were also questioned, particularly the birth outcomes, for which family nurses would have had a very limited time to intervene. So expecting to see an effect on birth weight of an intervention that only started 28 weeks of gestation might be difficult. Okay, so for all of those reasons, and because the FMP has evolved over time, the service that mothers receive now would be different to that it would have received in 2009-10, which is when the Building Blocks trial was recruiting. We wanted to evaluate whether we wanted to evaluate the real world effectiveness of the FMP for the whole cohort of mothers who had been enrolled, and to see if we could look at effects, including for smaller subgroups and for a wide range of outcomes. So the challenge with this type of evaluation is that we're trying to evaluate an intervention using observational data or administrative data that we had access to. Around 1 in 4 mothers in local authorities that offer the family nurse partnership would have been enrolled in the programme. There wasn't enough spaces commissioned to allow everybody to have a place. So this means that, we know that family nurses would have targeted the more vulnerable mothers, and that means that if we had sort of a crude comparison between those who were enrolled and those who weren't enrolled, we would likely see that outcomes for those who were enrolled, because they were the more vulnerable mothers, would have been independently worse than for mothers who weren't enrolled. So to get over this problem, we plan to use propensity score matching, which uses pre-pregnancy characteristics captured about the mother in hospital and education data sources and social care that might be, so these factors are associated with both enrolment in the FMP. There might be reasons why particular mothers were targeted for the intervention, and this allows us then to create balanced groups for analysis. We used linked administrative data for all mothers captured in Hospital Episode Statistics, or HES, and the National Pupil Database, NPD. The HES we used for outcomes for the mothers, health outcomes for the mothers and babies, and NPD for maternal and child education outcomes and child social care outcomes. So the characteristics that we have on the mother pre-pregnancy are the ones that we were using to build the propensity score. We don't have any, we don't use information on the outcomes that we're interested in evaluated, but we use things like area level deprivation, trajectories of hospital admissions in the 2 years prior to pregnancy, including for adversity related diagnoses, which include self-harm, violence and substance misuse, chronic conditions, whether the mother had ever been in care, the mother's key stage 2 and actually key stage 4 results, and special educational needs. And we also had demographic characteristics like ethnicity and maternal age and year of delivery. So all of this work was actually done before we started ECHILD, which links routinely HES and MPD. And I think this was probably the first time that we'd used linked health, education and children's social care data for the whole population, although it was just for the subset of mothers under the age of 24. Okay, so just a description of the cohort. We had 99,000 mothers who weren't enrolled in FMP and just over 30,000 who were enrolled in the FMP. And as we expected, there were important differences between the two groups. Those who were enrolled tended to be younger, slightly more deprived, have more hospital admissions prior to pregnancy, book late, and have a history of being in care, having a child protection plan, or having special educational needs recorded at school. And this is the reason why it was so important to do the propensity score matching. So when we're doing propensity score matching, what we're doing is constructing a logistic regression model with programme participation as the outcome variable, and then predicting each individual's probability of participating in that programme. We would then select matched controls for the FMP participants, so mothers with similar propensity scores, and then perform the analysis on the subsample of matched participants and controls. So in general, we're expecting the FMP participants to have higher propensity scores than the controls, but we're looking for good overlap between the groups. If there's little overlap, it's more difficult to create the matched cohort, and we'd have to exclude more of the FMP mothers. And then that means that the conclusions can only apply to those within the particular range of propensity scores. You can't extrapolate easily outside of that range. But here we can see that the FMP mothers do have higher propensity scores, that little blue blip at the right-hand side of the plot there, but we were able to match 95% of the FMP participants overall. So the 5% for whom we couldn't find a match were the ones with the higher probability of being enrolled. So we need to consider that when we're interpreting the results. But the propensity score matching seemed to go well. We checked the standardised differences of each of the characteristics that we had on the mother pre-pregnancy. And the groups that we ended up with were very well balanced in terms of the measured characteristics that we were trying to achieve balance on. Okay, so then looking at some results, what did we find when we compared outcomes for these two matched groups? The FMP group we saw was slightly more likely to have unplanned admissions for maltreatment or injury-related diagnoses. So that's the FMP group. The mothers that did have the intervention had greater rates of these unplanned admissions, or their children did. We saw they had slightly lower rates of child protection plans. I'm going to come back to the interpretation of these results in a second. In terms of child health and development outcomes, the FMP group were more likely to be low birth weight. They were more likely to have unplanned admissions, again, for any reason, not just the maltreatment-related diagnoses. But they were more likely to have a good level of development, which is a measure of school readiness at age 5, measured in the Eliazar Foundation Stage Profile. And then finally, the maternal outcomes, FMP mothers, again, were more likely to have these unplanned admissions for adversity-related diagnoses, unplanned admissions for mental health diagnoses. This is after birth, but they were less likely to have subsequent deliveries within 18 months of their first pregnancy or first delivery. Okay, some interesting results by subgroup. There's quite a lot of variation by region, and there was a pattern by deprivation whereby we saw that the beneficial effects seemed to be most strongly observed in those living in the most deprived areas, which is consistent with findings from the US trials where benefits were concentrated in those groups. However, none of these interactions were statistically significant, so we have to conclude that the effect of the FMP was consistent across subgroups. Okay, so how do we interpret these potentially conflicting outcomes? So overall, our findings support previous evaluations of the FMP, including the building blocks trial, which found no evidence of benefits for the FMP on child maltreatment outcomes, but did find some evidence in child development measures reflecting school readiness. So we were, replicating findings of the same intervention in a trial setting. But although we were able to check for balance between groups on the characteristics that we could measure, we weren't able to control for all of the factors that might have been associated with enrolment in the FMP. Health visitors and family nurses are really well trained to identify risks that aren't necessarily recorded in the data. For example, we only capture the most severe cases of violence that result in hospital admission in the data, and other cases of domestic violence, which might be associated with both being enrolled in the programme and some of the outcomes that we were looking at, might not have been recorded at all, might not have been disclosed, but could have been a reason, a residual confounder, basically. And the fact that we see these increased rates of lower birth weight in the FMP arm indicate that some of this bias by indication remains. So if we're already seeing at birth that the FMP mothers are giving birth to lower birth weight babies, that's a good indication that the groups weren't as balanced as we might hope they would have been. The second problem is the challenges interpreting outcomes in administrative data. So we saw consistently across the child and the mother that those in the FMP arm were more likely to have greater numbers of hospital attendances after birth. And we discussed this quite at length with some of the family nurse practitioners. And they said, well, for the mothers, for example, we spend a lot of time working with the mothers, trying to help them come to terms with, many of them, with the trauma that they have experienced up until being pregnant and giving birth. And that can bring up a lot of things, and it can make mothers more aware that there might be mental health issues, for example, that need to be addressed. And where there's not enough support in the community, they might not be able to see a GP, they might not know who to turn to, then presenting at A&E at a crisis point might be a reflection of that increased recognition of need. So it's about healthcare seeking behaviour. And the same applies to the children as well. If family nurses are going in and saying, are promoting positive health seeking behaviours, if your child falls over and hits their head, take them to the hospital, that would be an appropriate healthcare seeking behaviour that might result in these increased admissions. So we really need to think carefully about, okay, if we're going to see increased hospital admissions, how are we going to interpret that as an outcome? And then, are we capturing the right outcomes at all? There's lots of important outcomes that aren't captured in administrative data. There's such a high level of support for the programme that still exists based on qualitative data, but some of those more qualitative outcomes, like self-reported maternal mental health well-being, self-sufficiency, mother and child engagement and interaction, just aren't captured in the data. We hear some really strong stories about how the family nurses helped mothers and families with housing, with jobs, all of these things that are spread, widely over different services, and we might not be able to capture in just looking at these specific outcomes. So I think the lessons learned really for evaluating interventions, and we see this across a lot of our other studies looking at health visiting more generally, is that it's very, very difficult for all of these reasons to do this within administrative data. Residual confounding is always going to be a problem. There are always things that we can't capture in the data that mean that somebody gets a service or a more intensive service than another person. And we don't know anything about the social support within the house, whether there are grandparents there to add additional support, what the sort of social network and community is like for individuals or families based on this data. We don't have any measures of household income. So there's lots of missing pieces of information that mean that residual confounding is likely to remain a problem. And then, as I've said about the challenges of interpreting the outcomes, we really need to think carefully, I think, before we set out on an evaluation about how are we going to interpret this if we see it in the data? Do we think it's an indicator of increased underlying need, or is it a particular behaviour that could be explained in a different way? And then to sort of summarise the findings from the FMP study, I think there's still some uncertainty about the effectiveness of this early intervention in England, due to the limitations of the study design and the data that we had. But taking all of the evidence together, including from the trial, whilst it's unlikely that the FMP has measurable impacts on hard maltreatment outcomes, it does appear that there are some benefits in terms of child development. And as I've said, there's still a lot of support locally for the Family Nurse Partnership. Okay, I will stop there. Some references. We also looked at the effect of the Family Nurse Partnership being offered in a local authority on everybody in that local authority, or in all of the teenage mothers in that area, irrespective of whether or not they were offered the programme at an individual level, and we found sort of consistent results. So thank you for everybody who input into this study. We had a lot of really helpful conversations with the FMP national unit, which really guided how we interpreted our findings. And thank you very much for listening. Happy to take some questions at the end.
Thank you so much, Katie, for that really clear presentation and that interesting discussion on interpretation of findings, in particular. Okay, I would love to move on then to our second speaker, who I'll introduce. Our second speaker is Dr. Calum Webb. He's based at the University of Sheffield, where he joined the Sheffield Methods Institute as a British Academy postdoctoral research fellow back in 2021. And Calum's research explores socioeconomic inequalities in the child welfare system, their relationship to fiscal and social policy using quantitative research methods. Today, Calum's going to discuss results of a 3-year study applying novel analytical models to interrogate spend and investment across preventative support and child welfare interventions in England. If you're ready to share your slides, Calum, that'd be fantastic.
Yeah, thank you, Kat. Hopefully everyone can see the slides and can hear me okay. Okay, thank you so much for inviting me, and thank you for putting together this great event and the series of events. I'm really excited to hear from everyone working in this space. So my research, as Kat said, has been about looking at spending on preventative services in children's social care in the round. So rather than evaluating specific services, looking at if there is more investment in these kinds of preventative services, what kind of implications does that have for children's social care? That is rates of children in care, rates of child protection plans, rates of other kinds of interventions like children being in need. And for anyone who's familiar with this kind of area, it's notoriously difficult for a couple of reasons. But the main reason that interested me methodologically is that it's very difficult or perhaps ill-advised to compare spending between different local authorities. Local authorities like to put their spending into different buckets, and therefore if you're trying to use the local authorities as a basis for making some kind of inference on whether more spending means different outcomes, it doesn't work, because what those local authorities the reason they're spending more might just be because their accountants have different accounting practices. So from a methodological perspective, it interested me because I wanted to use these types of models called between models to, instead of focusing on differences between local authorities, to focus on the collective variation within local authorities over time. So looking at changes within local authorities over time.
Calum, sorry,
yeah.
Can I introduce you? It's Lucy. You're slightly muffled. Is there any way?
Okay. I can try changing my speaker from my headphones to my computer. Is that okay?
Yeah,
Sorry
come
about
on.
that. Sometimes
No,
it
it's fine.
does
We'll
this
give you the
with
time.
Zoom.
Fine.
Okay, is that any better?
Yes, it's definitely better. Thank you, Calum.
Okay, sorry, I think it's a specific Zoom thing. If there's any other problems, just interrupt me, no problem. Okay, so yeah, that was one of the reasons it was interesting. The other reason it was interesting is that often we have really good studies on individual interventions, especially interventions where they can be delivered to a family, where they can be delivered to a child, and they can be evaluated quite nicely. But it's quite difficult to make the case for a lot of community level interventions where it's quite difficult to imagine structuring an RCT or anything similar. So I'll say a little bit about outcomes. The study's focus was on a very, very small part of what preventative services offer to families and to children. And I really think that's important to keep in mind. In this study, I was just looking at whether there was a relationship between spending on preventative services and rates of intervention. But there's lots of other things that these local preventative services do that are not considered in this study. So they also talk about all of the things as well that were in the previous presentation, things about listening to parents, hearing their voices, responding to community needs. But there's also things about adherence to processes, things that are really important to ensure that children's and people's rights are maintained. For anyone who's, I guess, maybe more familiar with the health side than the children's social care side, I looked at 3 children's social care outcomes: the rates of children who are looked after, the rates of children who are placed on child protection plans, and the rates of children who are in need. A child in need, there's an acknowledgement from the local authority that they require additional services to have a good level of development, or for their development and health to not be impaired. Child protection plan usually means that there are some concerns, immediate concerns about the safety and well-being of the child, and that child has a social worker. And children being looked after in England, at least in the English context, usually means that a child is, firstly, their care is the responsibility of the local authority, and that could mean that they are placed in a foster home, in a residential home, or in some circumstances in independent accommodation. And preventative services spending referred to spending on children's centres, children under 5, family support services, services for young people, so youth work, youth centres, substance misuse services, and basically any services that fell under the DfE local authority spending that weren't related to safeguarding, which usually captures your social work spending, or related to children looked after. And I'm afraid this is a more of a old-fashioned administrative data usage, but still one that I think is important, and that the ADR's work helps researchers develop the skills to do. But I was looking at combining lots of local authority level published data across 13 years initially, but then just 8 years later on, where we have a comparable child poverty rate. And those were published in all kinds of different formats across the DfE, the ONS, Department for Working Pensions in some cases, and needed all bringing together and harmonizing. And then these were modeled using these within between models. And all of that data tidying process is available in an online repository. So just to go through some of the findings, and on the slides there's information about all of the findings from the project, but I'm just going to focus on a few sections here just in the interest of time. So the first finding was that there was quite strong evidence to suggest that investing in these kinds of services reduces the rates of children looked after and rates of children on child protection plans over a 2-year period. To put a specific number on that, every £100 decrease in family support, youth services, children's centres and other services per child was associated with an increase of around 3.5 children in care per 10,000 over the following 2 years. And also with a 2 per 10,000 increase in the number of children placed on child protection plans. For children in need rates, the findings were a little bit different. They tend to self-stabilize. So initially, when the spending on these services increases, you tend to see an increase in children in need rates, which is kind of what we would expect. The kind of thresholds to receive a service decrease. And then you would expect more children then receiving that service, which is a good thing. But then in the following year, they tend to equalize, they decrease by about the same amount, which suggests that of those children where that need for additional help and support isn't chronic, it's more acute, are receiving that support and then are no longer classed as in need. If you're thinking about an average size local authority, that 3.5 and that 2 number equates to around 20 more children in care in an average size local authority and 10 more children placed on child protection plans. And if we break this down over from 2009-10 to 2021-22, you'll see that we would have expected most of this impact to have happened very early on in the austerity agenda of the coalition government. One of the real challenges with only having a comparable measure of child poverty from around this point, from around 2014-15, is that we miss this really big reduction in service expenditure, service spending, that happened very early on in the decade, in the 2010s. So I think it's important to include that. And if you just have those changes in preventative services, which is not perfect because they are wrapped up even within local authorities a little bit with poverty, that can explain about 60% of the average increase in children looked after rates that there's been within local authorities. And also, if we're thinking about the scale of that in terms of national impacts, on average in a local authority, there's now £212 per child per year less spent on preventative services, and we would expect that to lead to around 8,300 more children in care nationally than there would be otherwise if those services had stayed at the same funding level. That still means they're likely to have increased, but not as much. And 8.3 thousand is around 10% of the number of children in care on a given day, I believe. And if we're comparing that with proposed uplifts in children's social care preventative services, really they don't quite match the scale of what's been reduced. So if you break down the 2022 care review's proposed uplift, it works out to about £1 billion per year increase, I believe. So we would expect that to have a really positive impact, 3,500 fewer children in care nationally, but far below the kind of impact that we would expect if we were able to return to the kinds of spending that we had in 2010. If I skip forward a little bit, just because of time, once we incorporate poverty into the model and we look just between 2014-15 and 2021-22, we start to see that a very large proportion, the largest proportion of the increase an average local authority has had, has been related to increases in poverty. So the orange area of the graph is the predicted increase in rates of children in care that we would expect from the average 3.7 around percentage point increase in child poverty. And then the green areas reflect the impact that the further cuts to preventative spending would have. And part of that is indirect through the ability of those services to intervene on rates of child poverty. So to be able to offer childcare, to be able to provide benefits advice. And it's really important to think about the cost saving effects of this investment. But equally, I do want to state that just even if this spending wasn't cost effective, we should still do it. The moral and human costs of not supporting families should really outweigh any of the economic costs, even if it costs money to support families to stay safely together rather than saves money. It's still probably something that we should do because it would prevent a lot of harm and trauma. But if you were doing a cost analysis and you were looking just at some of the immediate outcomes, so the reductions of children in care, improved mental health outcomes, by which I mean improved to the level of a child who's who's still in a deprived home environment but is not in care, and criminal justice outcomes, we'd expect about 30 pence of every pound spent to be returned within that 2-year period. But if you consider the potential impact on child poverty, then you'd expect much more of a return on the investment in those preventative services, about £2.75 for every £1 spent. And then I'm just going to talk very briefly about a couple of other findings, and then I'll stop to try and keep us to time. One of the things that always comes up is, well, can we just do what local authorities have been doing, which is increasing safeguarding spending? So the orange is the increase in safeguarding spending across 50% of local authorities, and the 50% closest to the median, and the green is the reduction in preventative services. The modelling that I've done seems to suggest that you can't do that. Actually, if you don't have enough preventative services in place and you increase safeguarding services, the result is that more children actually enter care. I think anyone who works in social work would probably understand the reasons why, that social workers don't have any resources to direct families to. They're left with very few avenues to explore other than potentially a child being in care. And the other thing that's really important to say is that these results aren't necessarily universal across the country. So if we just look at the outcomes for children looked after rate, and we break it down by the country, all of the green places are where we would expect an increase in preventative services to decrease rates of intervention, and the orange places are where we'd actually expect the reverse. That might seem counterintuitive with some of these places, but it's important to remember that green in this context means that we've been cutting the spending and the rates have been going up in those places because it's very effective. And the last thing to say as well is that it's really important to consider differences across age, ethnicity, gender. So the age group for which this spending seems to have the biggest impact is actually older children, particularly children who are aged over 16. Those seem to see the biggest benefits from investment, and also minoritized ethnic groups. So the impact of cuts to these preventative services are likely to see much bigger increases in rates of children in care for children from minoritized ethnic groups. Even if we ignore other ethnicity, which has quite a lot of missing data because it's censored, and we just focus on Black, Asian and mixed heritage children, the proportional effect of these services is almost twice as big as for white children. So I'll stop there because I think I'm out of time, or maybe slightly over time. But I'm able to put the link to the slides and the project website in the chat if anyone wants to read a little bit more about the findings or wants to get in touch with me, and hopefully we'll have some time for Q&A at the end.
Thank you so much, Calum, for that excellent presentation and for being able to condense such a huge amount of work into the presentation slot. Thank you very much. I encourage everybody to go and look at all those other wonderful slides that you sort of briefly saw popping up on the screen through the link. And yeah, please do put your questions in the Q&A function. Thank you. I'm going to introduce now our third wonderful speaker today to present their research. This is another member of the Community Catalyst project team and a researcher in epidemiology at UCL, Dr. Eliazar Luna. Eliazar is a current ADR UK research fellow, and today is going to showcase some of the findings emerging from his fellowship project. This works using linked administrative data from ECHILD to examine hospital contact patterns before and after children's social care referral across 3 groups of children in need, children subject to child protection plans, and children looked after. So I'll hand over to you now, Eliazar, if that's all right.
Thanks, Kat. I'm just gonna share my slides. So you should be seeing my slides now. And well, thank you for the introduction. As Kat mentioned, my name is Eliazar Luna. I'm a research fellow at the Institute of Child Health, and today I'll be talking about this piece of research, which is part of the ADR England Children at Risk of Poor Outcomes Community Catalyst, that is about hospital contacts of children involved with children's social care services in England using ECHILD. First, a little bit of context. So children who have been in contact with children's social services, or CSC, often face a set of adverse social, environmental, and family conditions put them at risk of poor outcomes. This is quite a sizable group. In England, it has been estimated that over a quarter of all children are identified as children in need. Just under 7% come under a child protection plan, and just over 3% are classified as children looked after by social services at least once before turning 18. So this is sort of like cumulative incidents we're talking about. Also, this work builds on previous work from the Catalyst, where they develop a stakeholder consultation, a scope review, and a research agenda. And some of the gaps highlighted were the underrepresentation of children in need and children under protection plan compared to children looked after, limited use of longitudinal administrative data, and the need for cross-sectional analysis that can provide a more holistic view of the children's journey through different services and their outcomes. It's now robustly established that children in contact with children's social services have higher healthcare utilization compared to those who are not in contact with social services. But the timing of the utilization and the use prior to being involved with CSC has not been examined. And also, we don't know much about the type of contacts, type of health contacts that they have, and the difference between the different groups of children in need, children on protection plan, and children looked after. That is why we describe and model the timing and number of hospital contacts 2 years before and after first involvement for these 3 groups. To do that, we used ECHILD. So this is a resource linking administrative records from educational records, health records, and social care records for children in England. And we built a retrospective cohort of children in contact with CSC for the first time during April 2009 and March 2018. So this gave us these 3 groups. For SEEN, this was over 1 million children. For CPP, just over 200,000, and for CLA, about 180,000 children in total. So they're about like quite large sample size. And the outcome that we had was monthly number of hospital contacts, and we categorized this into planned care and unplanned care. So for planned care, we have planned hospital admissions and outpatients appointments. For unplanned care, we have A&E attendances and unplanned hospital admissions. This figure here just illustrates how we examine healthcare utilization over time. So in the horizontal axis, we have time in years. I mentioned that we included those involved with CSC between April 2009 and March 2018. But since we're looking at healthcare utilization 2 years before and 2 years after, actually the range of healthcare data is from the years 2007 to 2020. In this figure, each circle represents a child and each of the bars represents healthcare utilization. But we center the time, we center at everything at time of CSC involvement. So it would look a little bit like this. So now we have each healthcare utilization indexed to months relative to CSC involvement from -2 years to 2 years. So 48 months in total. We use an interrupted time series design. The interruption here would be the being involved with CSC, and we estimated the pre and post intervention trends. So for that, we use a negative binomial regression with the outcome of monthly number of hospital contacts. We allow for an interaction between time and the intervention. So this allows us to both estimate the immediate change in the level of healthcare utilization at the moment of intervention, but also the trend change over time after this intervention. We also adjusted for the covariates of age, sex, ethnicity, and area level deprivation. And also, since there were a lot of hospital contacts around the time of CSC involvement, as you'll see later on, we also adjusted for acute healthcare utilization. And lastly, we also estimated a model using pre-involvement data only. So basically, this model tells us a little bit about the trend over time of hospital contacts, had they been not referred to CSC at all. So for the cohort characteristics, we see just briefly just a couple of things. The oldest group was CLA with a mean age of 10.9 years, followed by SIN with a mean age of 9.7. And then lastly, the youngest group was CPP at 8.4 years. Across all of this group, more than 70% of them were of white ethnicity. And there was a relatively even sex distribution between groups, maybe except for CLA, who had a slightly larger proportion of males. In total, there were more than 12 million hospital contacts examined. And the service that tended to be used most frequently was outpatient services that was responsible for more of these healthcare contacts. In this table here, we see an increase in the mean of hospital contacts after CSC involvement compared to the period before. This was true for all services except for unplanned admissions, which is not shown here, but I just wanted to briefly mention that. And we also see that the mean number of hospital contacts is higher for CLA with 11.8 mean number of hospital contacts overall, followed by SIN and CBP, who had a kind of similar level of hospital of healthcare utilization if we just look at the mean number of hospital contacts. Now, instead of showing you like a table with the different estimates on a Monday morning, I think it would be better to show you just these kind of graphs that illustrate a lot of the points that I would like to make. So I'll spend a little bit of time just like explaining this graph, and then we can just like go through them all. So here we have the observed monthly rate of monthly hospital contacts, which in this case is the pink dots. Of course, we have this by CSC group and by type of admission. So we have three CSC groups and 4 types of hospital contacts. So in total, there are 12 different models. And within this graph, you can also see 2 predicted models. The solid line is the predicted monthly rate of hospital contact with its 95% confidence interval. And the dashed line is the second model. This is the model that was used using pre-referral data only. This model shows the trend in healthcare utilization had there been no CSC involvement at all. And at year 1 and at year 2, I calculated the percentile difference in the outcome between these two models. Now, in general, not just in this graph, what we tend to see is a gradual increase in the monthly rate of hospital contacts before CSC involvement. Then around 2 to 3 months before, we see this sharp increase that peaks either at time 0 or at the first month, or sometimes even just before CSC involvement. And this sharp increase is followed by a sharp decrease as well. Then one of the things that interrupted time series allows us to do is to estimate this. What is this? Is the immediate level change at the time of intervention. And lastly, the other element that allows us to do due to the interaction between time and the intervention is to estimate the change in the slope in the second part of the graph. This captures the gradual effect that CSC involvement had on the outcome. So all these features, you will see it across the different models, but I thought just to spend maybe a little bit more time on this in the first one to just, so when I go through all of them, you'll see the similarities. So firstly, for planned care, we have these different groups. For children in need, we see that both planned admissions and outpatients appointment have a very similar pattern, but at a different scale. This is because outpatients appointments was a service that was used more frequently for everyone. And we see the same pattern that I showed you before, a gradual increase before CSC involvement, a significant level change. So this means that the rates increased, and then they don't go back at the level they were before CSC involvement. So they remain kind of elevated. And then we see a gradual decrease over time. And although the predicted rate had there been no CSC involvement, the dashed line shows lower rates at first. After 1 year, they're about the same. And after 2 years, the model of no intervention showed a monthly rate about 14% higher compared to the model with the intervention. For children under protection plan, we have a different pattern compared to SIN, right? We still have a very important level change. So this is about 40% increase at the moment of intervention for plan admissions, for example. However, the magnitude of the change in the slope after CSC intervention is a lot smaller. This basically can be seen by the similar slope before and after CSC involvement. And even though the model of no CSC involvement suggests a lower rate after 2 years, we have to keep in mind that we're talking about planned care here. So this is something that even if you have a lot of, it's not something negative by itself. And lastly, for CLA, we see a very similar pattern compared to SIN, only at a different scale, because as I mentioned before, children looked after tend to have higher healthcare utilization compared to these other two groups. Again, we see this very gradual increase in the monthly rate of planned care before CSC referral, then a sizable level change, and then the contrasting downward trend in the case of the model fitted considering CSC involvement, which is the solid line, and an upward trend in the model fitted with no CSC involvement. These two rates intersect after 2 years in the case of planned admissions and after 1 year in the case of outpatients appointments. So for planned care, in summary, we see a gradual increase in rates of hospital contacts in the 2 years before CSC involvement, a peak around the time of referral, similar patterns for children in need and children looked after, and for children under a protection plan, there is a level change, but little change in the slope after CSC involvement. Now, for unplanned care, which is basically A&E and unplanned admissions, we see for SEEN that we don't have an evidence for level change as we saw in the previous slide. And although there is an interaction between the intervention and time that modestly changed the slope, this is the slope is very similar. However, even this small change after 2 years compounds to about a 10% lower rate of unplanned care compared to this scenario with no CSC involvement. For CPP, in this group, we tend to see a small decrease actually in the rates of unplanned care before CSC involvement. And we do have some evidence of a level change. So the rates go up, they peak, and then they go down, but they don't go down quite to the same level as they were before CSC involvement. And then both the model with only pre-involvement data and the dashed line and the solid line, they tend to converge over time. Lastly, for CLA, again, we have the same pattern as seen, but at a different scale. And one of the unique features of this group was the large difference between the model with and without CSC involvement. So, for example, for unplanned admissions, the estimated rate after 2 years of CSC involvement is about 45% lower than in the model without intervention. For both A&E and unplanned admissions, being referred to CSC made the slope a little bit flatter and negative, which means fewer unplanned hospital contacts. And one of the elements that I want to mention, although it's not very well illustrated in this graph, is that I also justify different covariates that were included in the model. So I just want to briefly mention that in the case of age, younger children had higher healthcare utilization compared to older children. Females had lower rates of A&E and unplanned admissions, but higher rates of planned care. In terms of deprivation, children from more deprived areas had a higher rate of monthly hospital contacts compared to those living in less deprived areas. For ethnicity, children of Black, mixed, and any other ethnic groups had a lower contact rates than children of white ethnicity. In summary, children looked after had a higher healthcare utilization across services, followed by SEEN and CPP, who actually had very similar levels between them. Hospital contacts increased after CSC involvement for all services, except, as I mentioned before, for unplanned admissions, which actually decreased. A large proportion of all hospital contacts tended to occur in this narrow window of time of this couple of months. This was the peak that the graph had. Planned care showed an immediate level change in hospital contact, while unplanned care did not. And being involved with CSC was associated with decreasing rates of hospital contacts in most models. What does it all mean? Basically that the increase in overall healthcare utilization after CSC involvement is mostly driven by planned care as opposed to unplanned care. So being involved with CSC triggered an immediate increase in planned care, as seen in the model, and also CSC involvement changed the trend of healthcare utilization and shifted the system response a little bit from being more reactive to be more proactive. There are a lot of different limitations for this. For example, this relies on observational data that is not collected for research purposes. We adjusted for different elements that I mentioned, but of course, there's a lot of other elements that we did not control for. We don't have a control group or a control design that considers maybe an outcome that is unaffected by CSC involvement. And the model of the dashed line of just having the trends before CSC involvement assumes that this trend is linear over time, and that is quite a big of an assumption. And we also were not able to account for the kind of actual support received by these children. So we know that, they're a child in need or a child on a protection plan. Well, we don't know what kind of support they're actually getting, at least in our data. So that's what I wanted to talk about today, and I'm looking forward to any questions you might have.
Thank you, Eliazar, for that really fascinating presentation. I'm going to now swiftly pass you on to my colleague, Lucy Griffith, co-lead of the Community Catalyst project, to field the Q&A. That's all right, Lucy?
That's great. Thanks, Kat, and thanks to everyone for your questions. So, well, some of the questions have been answered actually. So my panelists have been super helpful already. Katie, I'll let you expand on this one. One of the questions that came in was you mentioned at the end of your talk that the findings of the project were replicated within local authorities delivering the nursing programme. Can you please expand on what you did for this work and what you found, please?
Yeah, so so the study that I mentioned briefly at the end didn't take an individual level approach. Was a particular mother enrolled in the FNP or wasn't she? It took a local area level approach and said the FNP is delivered in this area and it's not delivered in all local areas, and it's been decommissioned in some and it started at different times in others. So you've got sort of different local authorities having it over time at different periods. But if the FNP is in this local area at this particular time and it's giving places to a quarter of eligible mothers, what effect does it have overall on outcomes for teenage mothers who might have been eligible for the programme in that area? So that tries to overcome some of the problem with the individual level confounding by indication, because we're not looking at was this mother enrolled versus was this mother not. It's at the area level, what effect does this programme have? And secondly, it tries to look at any potential spillover effects or unintended consequences. So it could go either way. The learning and the training that the family nurses have who are in the family nurse partnership, that learning and those skills and that knowledge can be shared across other teams that might look after teenage mothers. So that might be a potential benefit of having the FNP, even though you can't reach everybody on the programme. Some of those skills might still benefit the other mothers. Conversely, if you have an area where the FNP is delivered, perhaps that diverts resources away from other teenage mothers, because services for teenage mothers in another area that didn't have the FNP might be greater for all mothers than they would have been in a local area with the FNP. So that's why we did it. And actually we found very similar results to the study that I went through in detail, which was that there doesn't appear to be any effects in the outcomes that we can measure in administrative data. And that points to another one of the questions, which I can answer now if that's okay, which was about, are there any data that we could use? I think if we're going to do this, I think what would be needed would be prospective data collection, not just looking at routinely collected information, but looking at some of those sort of softer outcomes that I was talking about, the maternal-child interaction and engagement. And the building blocks trial actually found some potential benefits on early child language development. So I think it's some of those things that aren't those hard outcomes that we can see in the administrative data that would need prospective data collection. Obviously that's a different type of approach. And I also think we should also be valuing the evidence that we get from qualitative studies in the same way that we would value the evidence from quantitative studies. And this is also relevant to, you know, other early interventions or services in the early years, like health visiting, for example. We might not be able to put a monetary figure on you know, what you will get back by supporting these services in the early years, but that doesn't mean there isn't a value. And we can see through qualitative studies what a huge dramatic effect it does have on some families. And yeah, I think we need to think about how we weight that type of evidence as well.
That's great. Thanks, Katie. Eliazar, I've got some questions for you. Do you know the main reasons for planned, unplanned hospital contacts across children with different social care interventions? Do you think they differ by different levels of interventions or similar?
So the main reasons, I guess, depends of how you define like what is the main reason. We have variables of admission methods that tells us a little bit, why that person or how that person came into that hospital contact in particular. And you do see a difference in these three different groups. So in the case of CLA, for example, you would see higher levels of unplanned care that are basically associated with emergency admissions as opposed to patients' appointments where it's more planned care. So it does differ by the level of these different social care interventions, which I assume is meant like these three different groups that we have of children in need, children on the protection plan, and children looked after. But we don't have more specific data about that the specific reasons for that particular health contact. We could have a more granular assessment and look at the different ICD-10 codes, for example, that were included in that particular hospital contact that can give us an idea of that. And I think I've done that for all patients' appointments, looking at the different specialty services that they were using. And you would see, for example, that, well, first, and there's also a role of age, but beyond that, you would see different profiles of children that, for example, CLA would use more mental health teams in terms of specialty in outpatients appointments compared to children in need or children on a protection plan. But at the same time, that might be also the effect of age because CLA are older and teenagers or children who are older tend to use mental health services more than children who are younger.
That's great. Thank you. And also, there's a sort of latest question. Can I ask if you've controlled for routine health checks in CLA? Do we have that data in the CLA data set?
No. What we had is basically if someone was assessed, and then if that person was found in need or not, or was put under a child protection plan, or is classified as a child in need, but we don't really have the data of the kind of support or specifically received for each children. We do have maybe something that the reason for being referred to social services, but the reason is the way it's recorded is hierarchical. So the primary need for almost everyone is more than 50% is abuse and or neglect. And even if you have, other factors, if you have abuse or neglect, that's the one that will be recorded in the data.
Great, thank you. Okay. How was time zero defined? Surely your graphs show the actual intervention happened about 3 months before your time zero. Perhaps preventative health practitioners trying to get children seen for unmet health needs. Also, does it suggest that involvement with health is the thing that leads to social care involvement?
That's a super interesting question, and I bang my head against the wall a lot of time to try to answer that. But the truth is, we don't know if these children accessed to preventative services before being involved with CSE. So time zero here is defined as after the first time as someone is classified as either a child in need, is placed under a child protection plan, or is a child looked after. But we don't have the data to know what kind of support they actually receive, even before or after the intervention, really. So we don't know if, for example, someone received a provision of preventative interventions that maybe had an influence on their healthcare utilization overall, because we don't really, local authorities are for them it's not mandatory to submit that data. And that is one of the huge issues that we have, especially for children in need, where the provision of the kind of support that they receive varies more widely compared to children on a protection plan or children looked after.
Great. And then last one for you. Maybe you've touched on this in your answers since, but do you think the patterns of change in unplanned hospital contacts by social care interventions depend on age? Would you expect more or fewer changes before and after interventions by younger or older children?
I think there are different profiles by age and service. For example, if you look at A&E attendances, children who tend to use it the most are young children, and then children in around like secondary school age. So yeah, there are different profiles, but I would say the pattern doesn't change that much. What tends to change more is the scale that we tend to see. So the patterns here tend to be like very robust. And also in the models, we adjusted for age in these three groups. So preschool age, primary school age, and secondary school age. In some sensitivity analysis or subgroup analysis really that I did, you would see that the scales tend to change more than the patterns. The patterns might change a little bit, but not massively by age group. But there is definitely a role of age in healthcare utilization. So people use services differently according to their age, and that's why one of the reasons why I wanted to include age. I wanted to adjust for age in these models.
Thank you, Eliazar. And there was a question on access to ECHILD. So Katie's posted the answer to that one. And then Calum, you've addressed your question, but I just wanted to say that I thought your presentation was a really fantastic example of how to communicate science so clearly in terms of the risks, or the forecasted risks in increasing numbers of children coming into care with the cuts to preventative services. I'm conscious that you did your work using local authority published data, and I was just wondering what your plans were in terms of potential use of some of the data that we can now access through trusted research environments.
Yeah, so I think it's a really great question, and I think what I'm really interested to see is more cross-level linkage. So I mean, maybe I'm getting ahead of everything, but I think it's really great to see how fantastic and in such a short period of time the individual level linkage has come along, and to see such fantastic projects. Eliazar's project, I don't know, this is ECHILD, it's lots of different things. Katie's project, and I think what would be great is if we are able to sort of work collectively to do more of that tidying of that local authority level data and being able to bring that in as well. I know sometimes it's possible and things can be added on, but because everything is released in so many different spreadsheets, it's often quite a big ask for the data owners. So if you say, oh, can I have the section 251s added to it? Can I have the RO, the RO3s or the RO5s? Can I have the the SSDA 903 return? And also then you're having to deal with more and more stakeholders. So if you're having to go to not just DOE and MOJ, but then let's say you need something that falls under something else, it becomes really difficult. But I think the more sort of open science that we can do in terms of documenting, tidying those spreadsheets, harmonizing them, combining them, even small things like how do you adjust for inflation when you're looking at these things, it's probably wiser to use something like the SPPI rather than the CPI. I think that opens up a lot more interesting questions that people working in that administrative data space can answer. So they can answer questions about how does the sort of funding of the local environment impact those individual outcomes, or how does, for instance, if we take Katie's research as an example, how does having a well-resourced youth and teenage pregnancy and substance abuse services and children's centres, how does having local authority that has high investment in those kinds of services interact with the provision of things like family nurse partnerships, which I think is really gets us closer to something that's more representative of often, I think, how a lot of practitioners are thinking about their work with families. So they're not just thinking about that's not to take away from any of the excellent research that's been done. They're all really important research questions, but being able to reflect the idea that a practitioner might say, oh yes, well, we tell parents that they should try and access this, and they should try and access this, and they should try and access this. But then if those things aren't available, there's a limit to what that singular or team of practitioners can do. So I'm really excited to see that. But I think it's been quite a big challenge bringing those different formats together. But all the time they're changing, and I think getting a bit easier to work with. And I think part of the relationships that ADR UK fosters between researchers and data owners or and government departments has probably been really helpful for that, because they're thinking not just about what they need to do in terms of their reporting, but how researchers might want to use that data. So I think that's probably not exactly an answer to your question.
Yeah, no, I completely agree. And I think it's a really rapidly changing landscape, isn't it, for data? But I think unlocking sort of national data sets and potential linkages to more local authority data, combining quantitative data with qualitative insights, etc., really then opens up that bigger picture and understanding children, their families, and to help us inform in terms of what works. So thanks, Calum. Great. I think we're at the end of our questions. There was a question. Someone said, yes, someone queried that we just had 3 talks. Yes, unfortunately, our 4th speaker was unable to join us today, but Sarah will be joining us hopefully at a future event. Kat, I'm going to hand back to you, and I'm also going to share the QR code, but thank you from me for our 3 speakers.
Thanks, Lucy. Thank you. So wrapping up ever so slightly early. Thanks for joining us today. Thank you so much, Katie, Calum, and Eliazar, again, for your excellent presentations, and for your discussions of your interpretation of findings, and how that kind of locates things, as Lucy was saying, back to kind of practitioner perspectives. As a social work practitioner myself, I find that particularly interesting, and something that's really, really important and worthwhile that we need to do more of. So yeah, we've had the privilege of hearing a range of really impactful findings. I think these definitely demonstrate the extreme usefulness of administrative data as a tool to enhance our understanding in this field, but also, to kind of highlight some of the evident challenges faced when we're thinking about using administrative data, and some of the other types of research we need to consider also. So yeah, fantastic. For more information about our project, the Community Catalyst Children at Risk of Poor Outcomes project, please do visit our microsite hosted by the ADR UK website. That link's been posted up to everybody in the chat function, I think, by one of my colleagues. This has got links to our recent reports, upcoming events. Our next event is planned for the 28th of July. And this is going to focus on research which cuts across the criminal justice and the family justice spaces. So yeah, would love to see as many of you as possible at that. And there'll be a link to register to that up soon on our microsite. So on behalf of the team that's organised the event, thank you so much for your participation, for your curiosity with your excellent questions. And yeah, we hope to see you very much at our future events. Thank you, everybody.
Thank you.